So we do this because culture eats strategy for breakfast. Those of you who are going to hear my talk tomorrow at the conference, I'll go into this in a lot more detail. But really, this is what it's all about in patient safety. There are massive behavioral challenges that we need to overcome. And rather than ignoring them, we should address the elephant in the room and deal with the elephant in the room. You know, when we first started trying to improve hand hygiene at our hospital, one of our patients had the audacity to ask one of our neurologists to clean their hands. And it was a bit of a longer story in that the first resident physician who came in to see the patient didn't clean their hands. The patient asked them to clean their hands and then asked for another resident physician because they got a bit of attitude back. So the second resident physician came in, cleaned their hands appropriately. The patient was very, thankful that they did this. And then when the staff physician came in to review the patient with the resident, she again asked the staff physician to clean their hands, and they sort of said, well, I did it down the hallway, so I'm good, kind of thing. Anyway, long story short, when the patient was leaving the clinic and booking a follow-up appointment, she said, I don't want that doctor, because that doctor didn't do what I asked. I asked them to clean their hands. And the neurologist yelled across the waiting room, don't ever come back to my clinic again. Get out. That's culture. You know, imagine one of our respiratory medicine physicians coming out of a room wearing full personal protective gear because a patient had respiratory syncytial virus and was about to walk into the next room wearing the same stuff, was stopped by one of our hand hygiene auditors who said, what are you doing, kind of thing. And the respiratory medicine physician, just sort of said, okay, you want me to take off my personal protective equipment? They took it off, formed it in a ball, and threw it at them. And they say Canadians are nice people. Not always, right? That's culture. Third story. On our solid organ transplant unit, one of our lung transplant surgeons walked out of the room not cleaning their hands, was stopped by one of the housekeeping staff who said, Doctor, you forgot to clean your hands. How do you think that's going to go? Usually very badly. In this case, the transplant surgeon said, oh, you're right, I forgot, thank you. Cleaned their hands and moved on. It's all about the culture. And so these approaches that we're learning today are all about trying to get at that culture. And I'll tell you right now, when I work with groups, I have no idea where it's going to lead. I don't come into a group and say, I'm going to twist your culture this way and you're going to be like this over here. I don't do that. I just start engaging people. And as you engage them, the way forward starts to emerge. So I now have no problem walking into organizations telling them I have no clue how to make your problem better. Why should I? I don't work here. I'm not from, obviously from my accent, I am not from here, right? I have no idea how to make things better. But the people you work with do. And so it's all about tapping into that resource. This is from a great book that I just love called Sorry I Broke Your Company, written by a senior consultant I think she was with either Deloitte or McKinsey, one of these very big international consulting firms. And she spent her entire career working with different businesses and telling them how to improve their business. And usually you would bring a whole bunch of tools and charts and things with you and get them to follow these practices, and then things will get better. And I love this quote. We've been led to believe that businesses, you could cross that out and put in healthcare, are logical and run by the numbers, and that their models and theories will provide step-by-step instructions on how to succeed. Does that sound like what we say every single bloody day? Right? We know what to do, people. It's obvious what we're supposed to do. But businesses are people, irrational, emotional, unpredictable, creative, oddly gifted, and sometimes ingenious, who don't operate according to the theories. That's the reality of what we're working with, right? One of you said it best, that you all are the same problem people, right? I love healthcare except for the people and the patients. Get rid of them and it would be awesome. That's the messy part, but that's what matters. This is a wonderful paper that came out of McKinsey and Company. It's pretty old now. It's 15 years old, but it's just as true today as it was 15 years ago. Some inconvenient truths about change management, which is what we're talking about today. What motivates you may not motivate them. So you know how you work in infection control and you're all about patient safety and you're seeing people that are catching infections in the hospital, potentially dying from that. You got into this field because you deeply believe that that's wrong. And I'm with you. That's why I got into this field too, right? That seems criminal to me that we would do that to people who came to us, trusting us, and we killed them. That seems wrong. But that's what motivates you. It's not necessarily what motivates them. It's not necessarily what's going to change their behavior. So we need to figure out what that is through engagement. Let them tell their own story. I'm seeing this currently in my own hospital right now where we're trying to dramatically improve patient safety. And we've got this deck of patient stories. So I'm going to be the senior administrator. I'm going to come in and tell you a story of something that happened to somebody somewhere. Who cares? That story may mean something to me, but it doesn't necessarily mean something to you. If I'm going to get you to change, I need you to start talking about things that matter to you, stories that matter to you. We had one ward in our hospital that was an absolute infection control nightmare. We had C. difficile outbreaks, MRSA outbreaks, you name the multi-drug resistant organism outbreak, we had it on that ward. It was terrible. We got into this very aggressive approach to things on that ward to the point where the chief nursing officer was sitting down with the nurses and reading the code of conduct from the nursing college and getting them to sign off. It was that nasty. None of that changed a thing. What changed a thing and changed everything on that ward to this day, now 5 years later, was one patient's story. But it was their story. They admitted an elderly man from home. He was living at home with his wife. They were independently living in their house. He was admitted with community-acquired pneumonia. And he was put on moxifloxacin. And about a week later, developed C. difficile. We had a lot of C. difficile on that ward, so it was pretty standard at that time. He developed C. difficile. His wife was in every day caring for him. She was feeding him. She was eating his food because she was living in the hospital, basically. Long story short, as an outpatient, she gets treated with antibiotics. She develops C. difficile. I have no doubt that we gave it to her. She gets admitted to a separate part of the hospital. Her husband goes on to get a colectomy. He dies in hospital. She never sees him again because now she's admitted somewhere else. She gets discharged about 3 months later into a long-term care home. That's it, their life's over. That story changed that entire unit because it was their story. They were the ones who were part of that family's life. And suddenly everything that we were fighting about went away and they started to see a way forward on how they were going to make things better. I can tell you that story and it might be upsetting, but I can tell you that story is repeated 100 times a day in all of our facilities. But they may have stories that mean something to them. So I can tell that story and then say, anybody in the audience have a story they want to share about what happened to a patient? When you're dealing with complex problems, stories trump data. Patient stories matter. And so we're very focused on data in our world. And it's not to say that the data aren't important. They are. But there's different types of data. It's not just the numbers. It's also the stories. And it's not just your story. It's their story. Because their story is going to motivate them more than what you're talking about. Both positive and negative are important, right? And so you want to focus on what's wrong, but you also want to focus on what's right. You don't do one or the other. You do both. So we used a positive deviance model in our hospital, meaning that we encouraged the behaviors of people that were doing what we wanted them to do. But we also went after the behaviors that were downright nasty. So if you're the physician throwing stuff at our hand hygiene auditors, I can't just ignore that. I have to deal with both. You were part of the problem. That was the biggest lesson for me in my career, was realizing that how I was approaching patient safety was getting me exactly where I had gotten to, which was nowhere. And it's very hard to look yourself in the mirror and realize that everything you've done at that point up until in your career is not helpful. You have to change how you work. Influence leaders may not be that influential. So there, the concept is that people are influenced by their peers. And so I can come in as the so-called expert in infection control and I can give advice, but what's going to be far more powerful to that frontline nurse is something that he or she heard from their colleague. And so those are the people that we're trying to get to influence things. Money may not motivate. We've noted that for years, and yet we continue to have pay for performance programs. I won't get into that anymore. The process is as important as the outcome. This is probably the most important point I'm going to make over the whole week that I'm here. Right? There's all sorts of papers in the infection control literature about an organization that brought in a certain bundle of best practices and they achieved remarkable outcomes. Right? We saw that with the University of Minnesota, came out with a thing on central line infections and how they dramatically decreased that. The VA hospitals in the States had dramatic reductions in MRSA, and they give you the practice bundles. This is what you're supposed to do. What those papers don't tell you is how they got people to comply with those bundles. That's where the money is. The bundles are bloody obvious. You know, here's an idea. Wash your hands before you stick a line in someone's neck. Wow. That's not the issue. The issue is that nobody's cleaning their hands before they put a central line in. Right? Simple things like for ventilator-associated pneumonias, keeping the head of the bed at 30 degrees. Turns out if you work in an ICU, that seems to be almost impossible. The head of the bed keeps going back down again. So it's how they got there that is so important. So when we share best practices, and let's say a hospital in Auckland has some amazing program that they've developed, which has dramatically improved something. When we share that with somewhere else in New Zealand, that outcome is important, but what's even more important is how did they get to those practice bundles? How did they get people to comply? And how are you going to do it in your setting that will get the same kind of compliance? It may not be the same way that they did it in Auckland. And good intentions are not enough. This is another important point. So you're coming to the workshop today. I've taught you one liberating structure, which is what these techniques are. I'm going to teach you about 4 or 5 more right after this. Some of you may think, hey, this is cool. I really want to use this. And then you're going to go back to your home base, and you're going to be surrounded by a culture that doesn't do this. And your good intentions might just die. And you may just go back to operating exactly the way that you did before, because the overwhelming pressure of the culture is such that you're not able to change. So in addition to coming to workshops like this, promise yourself that by the end of this week, if you have a session with other people, you'll use one of these techniques. Try it. You have to kind of keep reinforcing it to be able to use it. Otherwise, it's just blah, 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 and you've spent 3 hours with me. You really need to try it. So liberating structures, you can go to liberatingstructures.com. Yes, there's a website for this. It's a website for everything. And these are simple facilitation techniques that I use all the time when I'm working with groups. And so my purpose today, as I said, is to teach you how to use them, give you some resources like liberatingstructures.com, and even try to tell you some stories of when I've used them and how they've worked. These are meant to be done in the moment. You don't need to bring people to a conference. You don't need to bring them to a conference room. I've done these things in the nursing station as people are trying to work. Do they get annoyed? Yes. But I'm still getting somewhere when I do this. The point is, I don't have to take you away from your work. This is the so-called gateway liberating structure called TRIZ. This is part of a much larger Russian engineering technique. TRIZ stands for Theory of Inventive Problem Solving in Russian, which is why the letters are not working out for you. Okay. And what it is you're asking people to create a system which is exactly the opposite of what you're trying to achieve. So they used it for bridge building. How do we build a bridge where every single time it's going to collapse? So in this case, let's do it right now. How would you ensure a system whereby nobody would ever clean their hands. No sinks, no gel. What else?
Lots of gloves.
Lots of gloves. Yeah, what is it with gloves? The patients? I mean, one of the obvious things is, fire the lot of you, right? Just get rid of infection control. What else? Sorry?
Punish people for making anything.
Yeah. Punish washers. You get the idea. When you do this with a group of, it's a bit artificial here because you're all coming from different places. But when you do this with a group of frontline staff, let's say you're saying, okay guys, tomorrow we're going to have a little educational session on hand washing. And they all go, oh my God, no. Not another hand washing session. Please, I beg you, no more hand washing sessions. And you show up, no slides, no alcohol gel, no glow germ if you use that here, or any of those tools. You just say, guys, how do we ensure that none of you ever clean your hands? What are your ideas? They get really into it. Frontline healthcare workers have fairly cynical senses of humor. They love this kind of thing. So it's a way of engaging people, getting them to look outside of their normal culture. The next part of this is, which of these things are we currently doing now to some degree? So you're all from different areas, so again, it's a little bit artificial, but let's just go through it. Do you have sinks in every single room, everywhere where you need them? If you say yes, I'm going to fall over. No, you don't have those. Okay. Do you have gel everywhere where you need it? At point of care, people can always have access to gel. Are the dispensers always full? Yes and no, right? Depends where you work. Do you have lots of glove use? Yeah. You don't have no staff, but you have staff who are often telling you that they're too busy to listen to you and too busy to do these things. You are providing education. I have no doubt about that, so that one's not on the list. No products, a bit of the same up here already. I'm sure you all have patience. Measurement. Is measurement going the way you want it to go? Are you feeding it back in ways that people can understand it? Do they pay attention to it? I've worked with some organizations where they would post the hand hygiene numbers on the hospital intranet, but they wanted staff to have to go to click on the numbers to see them because the attitude was, well, why should I make it easy for you to see the numbers? Well, because you should make it easy for them to see the numbers, but it was almost this us versus them kind of thing. I know you have infection control programs, but you may very well not have enough people. Leadership. How many of you have leaderships which say this is important, but fundamentally it's just kind of something they say? It's not something that is necessarily the heart and soul of the organization. Like, do they really mean it? Do you have reminders that mean something to your staff, or are they generic posters or no posters or things like that? We don't punish people who clean their hands, but in a way we do, because how many of you have found somebody who's good at hand washing and you decide you want to make them a hand hygiene champion, you give them a button, and now they're supposed to go out and tell people to clean their hands? You're kind of punishing them in a way, right? So the purpose of this exercise is to show all the things that we're currently doing that is making people not clean their hands. So one of the best examples of this was at one of our cancer hospitals where we did this exercise, this exact exercise. And it was a mixed group. So we had nursing, pharmacists, housekeeping staff, 1 or 2 physicians, a bunch of different people in the room. Went through the list. And different people are yelling out different things. And what was remarkable is that the housekeeping staff yelled out all sorts of things related to their role. So make sure the gel dispensers are always empty was one of the things they yelled out. And I think until that moment, they had never really thought of themselves as having an important role in patient safety because they're the housekeeping staff, and we don't tend to treat that group particularly well. So one of their ideas was, one of their ideas was to keep the alcohol gel dispensers empty all the time. The third part of this exercise is there anything on this list that you want to start working on now that would make this problem a little bit better? So if you were a group of frontline healthcare workers, you might say, you know what, we're going to focus on glove use. That's the thing we want to focus on. Okay, my job is just to engage them. It's not to filter their ideas. I might think you really need to work on getting more product because the dispensers are always empty, but I'm going to keep that to myself because that's my idea. That's like me telling my emergency room physician that you have plenty of time to clean your hands, and you know how that's going to go over. So here, I'm engaging them. They come up with the idea of focusing on glove use. You go, that's great. I'll come back next week, see how you're doing, and you're going to figure out how to decrease your glove use. And you're going to tell me whether you think you've actually achieved that and how you're going to measure it. So what I'm doing is I'm transferring the ownership from me onto the frontline staff, and they're coming up with an idea that makes sense to them. So let's say I do TRIZ on 3 different wards. They come up with a similar list on every single ward, but I guarantee you when you ask them, what do you want to focus on, it'll be different. So let me tell you one little story about this, about how it worked. So we were working with a hospital in upstate New York where they wanted to improve hand washing. We did this exercise in the nursing station. I still remember it. They were very hostile. They were trying to eat their lunch and do their documentation and things, and there these 2 idiot Canadians show up, and we're doing all this stuff with them, and they. But we got a list, and one of their ideas was we need to put more alcohol gel up in the rooms. That's obvious. When you walked around this hospital, there were a bunch of double rooms. They had 1 alcohol gel bottle outside of the room, but nothing inside the room. It's an obvious human factors thing that you should have some in the room. But I didn't say that. I said, that's a great idea. Why don't you put dots on the wall where you want the alcohol gel, and we'll work with facilities to get them to put the alcohol gel where you want it. Key thing is the idea came from them. We install the gel. Over the next 6 months, their hand hygiene compliance starts to go up and up and up, and they're doing much, much better on their audits. So much better that the chief nursing officer of the organization says, this is brilliant. We're going to install alcohol gel between all the beds on all of our wards. And I said, no, don't do that. Not yet. Let's go to the next ward, do exactly the same exercise, and see what they say. What they said was they wanted to carry it on their waists. Okay, personally, I'd rather have it on the wall than on my waist. Have you ever used that stuff? It squirts all on your shoes. And anyway, they wanted to have it, carry it. The leadership said, no, that's stupid. We should standardize this. It already worked there. It's going to work here. I said, no. Let them, if you've engaged them, let them follow through on their idea. They had the stuff in stores, so it wasn't like they couldn't get the product. So they got the product. They carried it around. They started to see improvement. Now you've got 2 wards improving, but using very different approaches. Then a bunch of stuff happens. The nurse managers are chatting with each other. All these things go on. And as a group, the organization decides, we're going to put it between the A and the B bed in all of these double rooms. And it was all the frontline staff who thought that was a great idea. And then bam, the whole organization switched to it. This is a great example of going slow to go fast. Right? We're very bad at that in healthcare. And what I mean by that is, you see a good idea, you don't think about it, you just tell other people to do it. This is about, you see a good idea, you stop, take a couple breaths, go to the next group, engage them, and if they come up with a different good idea, let them do that. It may be that 3 months later, they all adopt the first idea and it's all uniform. I don't know how it's going to go, but if you didn't take that time, the second unit is going to tell you what a stupid idea this was. Because those idiots on 4B do it, just doesn't mean that we're going to do it. So that's part of the thinking behind this approach, is you give people time to spin their wheels and figure out what's going to work for them. So TRIZ, just to review it, how do we make this the opposite of what we want to achieve? How do we make every patient fall? How do we give every patient a surgical site infection? How do we make our patients the most annoyed, angry patients in the entire country that write nothing but letters to the editor of the local newspaper? That's the question. The next part is, write all those down. The next part, second part, which of these things are we currently doing? And your job as a facilitator is to draw some of these things out, right? So for example, everybody has some infection control people, but they may not have enough. So let's see which of these are sort of half true. And then the third part is, which of these things would you like to start working on to make it better? Like this is something literally you could use tomorrow. You don't need any prep for this, you just go in and do it.